We have got, I think, one or two speakers short, but we will utilize that time in the question answer session. And I think it's better that we keep the question answer till the after the last talk. So I welcome and invite Mr. Slavomir to present his first talk, that is about the challenging pediatric retinal detachment. So I will invite, first of all, Mohammed Samir to give his presentation, while the other presentation is to be downloaded. So he is going to talk about K-Pro, the magic window. Mohammed Samir.
First of all, I would like to thank my colleagues. Thank you, Dr. Kashif, very much. I want to thank my colleague and brother, Dr. Hussein Khakan, and all the group for giving me the opportunity to come again to Pakistan. I will speak today about three topics. My first topic is the K-Pro, the temporary K-Pro. As we see here, we sometimes are confronted with an opacified cornea and a retina problem. So first of all, I would like to share this case, 29-year-old male with total corneal opacity due to hypopyon ulcer, and his visual acuity was hand motion. LUBM showed amalgamated anterior segment, ultrasound showed total retinal detachment. This is the cornea, totally opacified, and this is the ultrasound. The ultrasound is showing retinal detachment. So how to deal this issue? The best to deal this issue is using the temporary keratoprosthesis. Putting this is the suction terrifying as we are watching the video, moving this diseased button like we are watching, putting this this is the temporary K-Pro, temporary keratoprosthesis. Doing vitrectomy, as we see here, the K-Pro give us a very beautiful visualization and very neat visualization. And as well as I can use a bimanual technique like this to cut the subretinal band, submacular band. My assistant put the light on directly on the K-Pro. No need for putting an extra trocar and doing by manual surgery like this and doing laser, and it's very nice visualization as we see. And after that, putting the new cornea button. This is before and this is after by 2 weeks. And this is visual acuity improved to 360 after 1 month of the surgery, and the corneal graft after 1 month. In this case, I put silicone oil, and I removed the silicone oil after 4 weeks, because if you leave the silicone oil for much more period, you may induce corneal problems or decompensation. And this is the retina in place after 1 month of surgery, and taking these photos through the new button just after 1 month. The second case, a 22-year-old patient, has a post-traumatic silicone oil removal, corneal decompensation. It was trauma with traumatic retinal detachment, done vitrectomy and silicone oil, and after removal of the silicone oil, he has this cornea with decompensation. At the first of the surgery, I tried to work in this corneal window, but it wasn't such helpful. So I shifted to the temporary keratoprosthesis, the temporary K-Pro, using the suction terrifying, as we see here, and removing of this button. Removing the button. We should take care that to put this infusion before doing anything to get a safe intraocular pressure while working. This is the case after I entered. As we see here, there is here much fibrosis. Sometimes we can put viscoelastic material at this part, so you can see more well. So we don't put saline, of course, in these cases as the cornea, but putting the viscoelastic material will make the visualization is more helpful and more assistant. In this case, I revised the retina. There was a break on the attached retina here. This is a break and surrounded by fibrous tissue. No need for removal of the fibrous tissue to induce more harm. So just I did laser around this break, and I left this patient just on gas, on SF6. After removal of the K-Pro, we will put at the same session the new cornea or the new healthy pattern. The last case here is the 19-year-old patient post-vitrectomy corneal decompensation, as we see here, and he has, with the corneal decompensation, he has a vitreous hemorrhage at the vitreous cavity. Doing the same, putting before putting the K-Pro, we removed this IOL, this Sensar 3-piece IOL, as he has a compensation. May be the cause of this compensation or contributing factor in this patient, so we removed the IOL. We put the temporary K-Pro with Prolene 60 in these 4 ports, entering and do the vitrectomy, removal of the vitreous hemorrhage, as we see, and entering in the vitreous cavity after that, doing vitrectomy and removal of the premacular hemorrhage, as we are going to watch in the video. You see that the visualization is very good using the temporary K-Pro. It sometimes, I can say that it's better than the normal cornea, removing of this premacular hemorrhage, as we see, and at the end putting the healthy pattern in these patients. So the take-home message that the temporary K-Pro is a magic window. It provides you with a magic window that you can end your target at the same session, removal of the diseased button, dealing with the retina problem, and putting at last the healthy pattern. At the end of my presentation, I would like to invite you all to Alexandria Vitro-Retinal Society Conference. It will be held in 28-30 August 2024 in Alexandria. And thank you very much. Shukriya.
Okay, thank you so much for this nice presentation. I have never seen such kind of cases. Samir, I have 2 questions. What's the material of this temporary prosthesis, and what's the refractive power of it? So is it 0 refractive power, or there is some...
Again, please, is it what?
What's the material? Yeah, the material. Is it
Material of the
silicone, the
K-Pro.
PMMA?
Material of the K-Pro, she's asking.
Again, please.
The K-Pro
Samir,
is...
the material,
I mean, it is plastic
is
or
it
silicone
made?
or...
You speak about what in the K-Pro?
Yeah, K-Pro, the material of the K-Pro. Is it silicone or
No,
the
yes,
PMMA? Or...
it's PMMA. This is a very good
Okay.
question. Yeah. The
Okay.
K-Pro is PMMA, and it can be disinfected using the plasma. Okay,
Alright.
we can use it more than one time using the plasma this disinfection. This is temporary K-Pro. This is not like the
Okay.
Boston, which is permanent K-Pro.
Okay.
It's just for the operation. Okay, and it's found in many companies, Indian companies and Pakistani companies as well.
And what's the refractive power of this?
The refractive part of the case, after using the the K-Pro is a very good visual window. Okay? It doesn't affect the patient after that. Just removal and putting the new button, and everything will take time to heal.
All right, thank you.
Thank you very much.
Yes.
Very short comment. Thank you so much for the nice videos you have seen. So actually, we do the K-Pros as well, but now how we reduced the usage of the K-Pros. For example, the cases you have shown here, the last 2 cases. The first case, it was a total glaucoma and all the layers of the cornea is affected. So mostly when there is the PB case or there is some dystrophies which mainly stays in the anterior stroma of the cornea. mostly what we do is that we do the ALK, anterior
DALK.
lamellar
You do DALK.
keratectomy.
Yes.
Yeah, so partially. If you leave there about 20% of the stroma, you will be able to see the retina, and you don't need to trepine
Yes.
the cornea. You can maintain the integrity
Yeah.
of the eye, and at the end you can leave it just a lamellar stroma.
I totally agree with you.
Yeah,
If you can use the DALK instead of penetrating keratoplasty, it will be better than doing this.
Yeah,
Yeah.
exactly. So this is what we do now, and
Yes.
we reduce now the numbers of the, because when you do the optical PKP at the end in the inflamed eye, so in the long run, actually they get rejected in most of the time. So
Yes,
but it was amazing. Yeah.
the success rate of the DALK is better than the PKB, but not all the cases are amenable to do
Yeah,
DALK surgery.
exactly.
Yes,
Thank
thank
you.
you
Very
very
nice.
much.
Yes, that's a good suggestion. Yes, Dr. Yahya, you can ask one question.
Last question.
Hello, it's very nice talk. So my question is that what are your steps, especially in second case you mentioned that you close the eye on gas. So when you're removing the K-Pro and putting a new graft in, so when will be the gas injected? After the cornea or you?
No, at the end of the surgery. After putting the cornea and after all the corneal suture are totally packed,
Then you
there
go
is no
to-
leak. Yes,
then you
I
go to-
enter again. Yes, I enter again and do air fluid exchange.
Okay.
Yes, and put the gas. Thank you very much.
Thank you very much, Dr. Sameer. It was a very nice presentation. Do we have Dr. Yahya over here? He's the next speaker. Dr. Yahya is not here probably. So I think, Dr. Sameer, you go ahead with your second presentation as well. The second presentation of Dr. Sameer is about how to manage post-diabetic vitrectomy hemorrhage.
By the submacular hemorrhage. How to manage the submacular hemorrhage? Bismillah ar-Rahman ar-Rahim. First of all, this is 21 years old patient with blunt ocular trauma, mild vitreous hemorrhage, and submacular hemorrhage since 1 week. Okay, this is the submacular hemorrhage. So it takes about 2 weeks to 3 weeks, and the patient is a worker and he's in very good need for vision. So he needs to solve this problem. How to solve the problem? He had taken some sort of medical treatment with no improvement. So I decided to make.
Okay.
This is the OCT of the
So
patient.
next I
This is
will
the new
call you.
sensory attachment. This is the blood.
Because there is no one else.
So I decided to do what's called hydropneumatic displacement of this hemorrhage. The hydropneumatic displacement, no need for injection TPA, just injection air and saline using the 41 gauge cannula as we see here. So after doing vitrectomy and shaving the vitreous base and searching for any breaks as it is a traumatic vitreous hemorrhage, separation of the posterior hyaloid, which is very important in these cases to dissect the posterior hyaloid. After removing the posterior hyaloid, I usually stain the posterior hyaloid with triamcinolone as we are watching the video. After that, I entered with the 41 gauge needle from DORC and injecting submacular air and saline. This saline will dissolve this blood, and the air will give a part and will give space and room for this hemorrhage to dissolve and descend away, move away from the macula, as we see here in this video. So this is the photo of the patient with after about 1 week or 10 days, there is no hemorrhage again, and this is the OCT of the patient back to normal. There is no hemorrhage, there is no neurosensory detachment. The other case is a 65-year-old patient with hemorrhagic CNV. This is a very severe CNV. In these cases, we do TPA. So my plan was to inject submacular TPA. I used a new cannula, which is the 40 gauge cannula, the inside to needle. This cannula is, I think it's better than the first one because it is stainless steel or something like, it's more rigid and you can depend on it and you can reuse it after sterilization. So, doing vitrectomy, removal of the vitreous hemorrhage of the patient as we see here, removing this posterior hyaloid tangled with blood as we see, and after removal of the vitreous hemorrhage and after removal of the posterior hyaloid, as we do, all of us, as a routine, we are going to deal with this massive submacular blood clot due to the CNV using the 40 gauge cannula. I usually do vitreous-based shaving for most of my cases, as we see here. And after that, we are going to introduce the 40 gauge cannula and trying to inject submacular TBA. The TBA, tissue plasminogen activator, it's a drug used for clotting purposes, and it's usually found in the ICU of the hospitals. It's not in the ordinary pharmacies. So injecting, as we see here, injecting TBA as well as an air bubble. The air bubble is injected to perform a room for this hemorrhage to escape from the macula, and the TBA for dissolving of that clot, as we see here. Sometimes it's better to do the injection of the air at the inferior part to give space for the blood and the clotted blood after it's dissolved to descend away from the macula, as we see here in the video. You should be cautious because you may induce an iatrogenic macular hole. So this is second day post-operative. This is the air bubble, and this is, as we see here, this is all of the, most of the blood clot dissolved and is not found. The patient gained vision. The patient felt that he is improved. The last case I want to see here, that is not always a piece of cake. It is not always a piece of cake. This is a traumatic vitreous hemorrhage with traumatic submacular hemorrhage since about 6 weeks. And this woman has a problem with this hemorrhage doing metamorphopsia and blocking the central vision. So I used the same way by using the 41 gauge cannula. This is a new cannula. But in this time I used the machine, not injecting by my hands. I used the machine, the automated injection of the Alcon constellation, and it is not as always as a piece of cake. While performing this injection, we will see here an iatrogenic complication from the surgeon, who is me in this case, inducing macular hole. So not all the times it is a piece of cake, and you have to inject slowly and steadily and take care not to do, as I said, an iatrogenic macular hole. How to deal with this situation? I injected BBG, and I did, as we are going to see in the video, macular rhexis, ILM rhexis, and leave the patient on gas, on SF6, as we are going to see here. So my take-home message is the submacular hemorrhage is a very important issue to solve in patients. As we see here, CNV, hemorrhagic CNV, or traumatic hemorrhage. We can do hydropneumatic displacement, or we can use the TBA, and we should be very cautious while using the injection because of the fear to induce an iatrogenic macular hole. And thank you very much.
Questions or comments? Very nice presentations. So I'll ask the next speaker, Dr. Slavomir, for his talk on challenging pediatric retinal detachment.
Good afternoon, everybody. Thank you for having me here, and thank you, organizers, for the invitation. I am for the first time here in Lahore, and it's really great meeting. I hope it's not the last one. I'm going to talk to you about actually our protocol in our hospital, how we operate kids and how we deal with pediatric cases. One of the most important lessons which I learned from my mentor, Professor Tassignon, is the answer for the question why we suture all the wounds in cataract surgery. We suture not only because they have to be watertight, but also because we have to do everything to we have to do everything to help these kids. And otherwise, if we lose the eye because we wouldn't done something what you should, it's unbearable. And the problem with pediatric retinal detachment, it's much more serious than only the leakage of the wounds. This is a case of 10 years old girl after giant retinal tears. You see looks very well under the silicone oil after 1 month, but in the second month of follow-up, you are able to see some PVR. It's coming up, even more exaggerated at 3 months. So if we smell PVR, it's coming up, we have actually 3 things to do. 360 buckle is mandatory. Nowadays, we exchange the lens before we try to preserve crystalline lens, and of course, we do pars-plana vitrectomy with the 5000 centistock silicone oil tamponade. Of course, sometimes we have luck. This is a case of 7-year-old boy after arrow trauma after perforation of eye globe. The case was cancelled from the other treatment in the other hospital, and we do everything what we should do, and this is 3 years after silicone oil removal and with the best corrected visual acuity 0.5. So actually we should never give up. Why 360 buckle in every case, even in case of giant retinal tears? We all know we don't need buckle to, in cases of 360 giant retinal tear, to attach the retina, but we need it later on to support ciliary body, to increase, because the biggest problem in that eye, it's unfortunately hypotony. So the only way to increase IOP is to construct the eye and take care of ciliary body. This is a complicated case. One of my first cases with Tassignon lens, and actually I had dislocation of Tassignon lens only twice, one in this pediatric case, but it's easy to fix, just to lift it up and place between the both capsule. And this is how the eye looks like now 4 years after silicone oil removal, after astonishing visual acuity with 0.5. And this is the other eye of the eye. You can see the eye as a little bit, has a little bit cyclorotation, but luckily it's not the problem because the boy hasn't binocular vision. So 360 for supporting the ciliary body, 360 buckle if we place, it doesn't change the position of the ciliary body because there is a cleft anyway, but we, as I mentioned before, we construct the eye and we increase the IOP therefore. We need also buckle because of PVR. We all know that when we have this small space below the silicone oil, this is the highest concentration of proliferative agents, and when we put a buckle, we increase the space, and this is the reason why maybe one of the reasons why the buckle is so effective, that kind of surgery. Why exchange of lace, why exchange of crystalline lens? Because when I review all my cases, when I failed, it was always because I want to preserve the lens in kids. And the price you have to pay for that is very frequently, first of all, not completely vitreous removal, and maybe the second thing, which is maybe more important, not adequately tamponade effects. So this is the 10-year-old boy which I've operated, 8 years old, which I operated 10 years ago with the preservation of crystalline lens, you know, you can see it's possible, but nowadays I would never risk that situation. I would exchange the lens for Tassignon lens, even with the sacrifice of the accommodation of that kids. Why back in the lens? Because both capsules are placed inside the groove around the lens, and there is no synechiae, even if it's most advanced disease. This is the eye after in ROP complication after retinal detachment. This is 11 years old girl with von Hippel-Lindau syndrome, one eye total retinal detachment. This is how it looks like postoperatively, and the problem was with the second eye. The eye was resistant for radiation and for laser therapy, so we decided to go for surgery, and this is how it looks like after the operation. But look, both eyes, how it looks the anterior segment like. So when I have that kind of configuration, so 11 years old boy with high myopic eyes, and with after previous laser, this is the only eye. The previous eye was lost due to retinal detachment. I do routinely surgery like this, so Tassignon lens, 360 buckle, and vitrectomy. Of course, I suture off all the incisions. This is one of for retinal surgeon, I hope all agree with me, this is one of the most terrifying cases, also in terms of follow-up, and also for due to responsibility for that child. And this is how it looks like after silicone oil removal. And the last thing which we are going to use in kids, this is, you probably know it, but it's an old idea. It's a Chinese product for the phthisis eye with hypotony eyes. This is foldable capsular vitreous body. We know that when we have shutdown of ciliary body, the eye shrinks, and when it shrinks, the silicone oil comes to the AC, touch the cornea, and the cornea get hazy. So there's a very simple idea to close the silicone oil in the, for example, silicone capsule, just to avoid the migration of silicone oil to the AC. And we have done actually 5 of that cases. They need preoperative measurements, axial length, the status of ciliary body, and the position of the eye also in CT scans. But this is how it looks like. This is actually the 1st generation of that product. The second one was we were able to inject with the injector. The first one you have to suture to the sclera, and I think this is one of the very interesting things which comes on the market right now. Thank you very much.
Are there any comments or any yes, please.
Thank you for the nice talk. I want to ask about Tassignon lens. When it falls down and we relocate, so does this lens has any specific anterior and posterior surface, or it works in either way?
No, it doesn't require any specific position. So both sides are okay. You just grab the oval haptic, and you just put it into the AC, or even.
So we should not confuse anterior and posterior, right? So it has to be placed properly.
You shouldn't. Only that, because there are also toric versions. So you can, if it's a toric, there's a toric mark. You have to be careful with the toric, but there is no difference.
Okay, thank
you. I would like to ask a question. This is a very nice presentation. Thank you very much for this nice presentation. I would like to ask you, what's your nomogram for putting these IOLs in children about 3 years age, 2 years age for congenital. Do you use this Tassignon lens in congenital cataracts?
Yes, we do. This is our lens of choice. Actually, there are two reasons behind that. First of all, there is no PCO, not at all. Actually, 3 reasons. So if you do it incorrectly way, there is never PCO. This is the first reason. The second reason, in many cases, you can avoid anterior vitrectomy. If you avoid anterior vitrectomy, the risk of retinal detachment later on is quite lower, and the most important thing, the risk of glaucoma is almost zero, because we all know from Robert Stegman, who has actually huge experience with cataract surgery in pediatric cases, that if you not touch the vitreous, the kids don't have glaucoma. Yeah, and this is also the only, because it's the hydrophilic lens, this is the only lens you can exchange later on when the refraction is not correct.
Is that lens hydrophobic? This is my next question. It is hydrophobic?
Yeah,
or
no. It's not hydrophobic one, it's the hydrophilic one, because hydrophobic, I would say it's too rigid, but this is the hydrophilic one made from Colaber 4th generation, so the calcification rate, it's actually 0.06. It happens, but very rare.
But I think, do you think and do you agree me that using hydrophobic lenses in children is the lens of choice, the hydrophobic one is the lens of choice to put in these children rather than hydrophilic one to be aware of, to lessen the incidence of synechia and uveitis post-operative in this age group?
Yes, if you put it in the back, but if you put both capsules inside the lens, so the both capsules are glued together, so you have never a synechia.
We put 3-piece IOL in Alexandria.
Yes.
We have a lot of experience. We have an eminent professor, Dr. Nihal Shakankiri, one of the eminent professors all over the world in pediatric cataract, and she is our mentor. I think we had learned from her to put the bag in the IOL, not the IOL in the bag. It's
Yes.
you know this technique using the 3-piece IOL like Sensar, for example. So actually use Sensar and put the bag in the IOL.
Yes, you are right. This is actually the standard of technique. You do optic capture and the haptic, they stay in the back, and you put the optic behind the capture. That's right. But in that cases, you have also, you might have migration of PCO according, just past the IOL optic. I saw cases like that. It's not possible with Tassignon lens because the cells they are closed, so there is no other migration.
Thank you very much.
Thank you.
Anyone has any questions?
A second.
Any questions? Okay.
Yes, I just want to share you an idea. This is a short case series study of combined keratoplasty and pars plana vitrectomy in patients with posterior segment emergency. So actually we had 3 cases. We operated 3 cases like that. And this is the first one, 44 years old man after the explosion. It was double-side penetrating coronal sclera wound with traumatic cataract, retinal detachment, intraocular foreign bodies. And this is how we deal with it. So we replaced the lens. And interesting is that instead of Landes or Eckert keratoprothesis, we used just soft contact lens. This is not our idea. This is idea of German colleagues, but we had a time in our hospital that we couldn't afford that kind of landers of Eckhart keratoprothesis, and this soft contact lens sutures with the Weichel 70 works quite well. Of course, this is we were able to preserve light perception in this case. The second case was the endophthalmitis case after silicone oil removal, and we have made the same procedure. This is already after first vitrectomy with silicone oil, and this is how it looks at the end. And the last case, it's actually complicated primary vitrectomy due to retinal detachment with gas. The surgery was made elsewhere, not in our hospital, and this is actually it was massive hemorrhage. Our colleagues tried to make anterior chamber removal of blood, but unfortunately it didn't work, so the patient was referred to us. We've done corneal transplantation. You can see the imbibition of the cornea. It was not possible to lavage the anterior chamber, and once again placing this soft contact lenses, and the retina was also detached with choroidal detachment. So I decided to leave the perfluorodecaline for 2 weeks, and this is unfortunately when we order the corneas in emergency cases, sometimes they are for very weak quality. So this is how it looks like. So I left the eye filled with PFCL, and this is the second surgery. After 2 weeks, I was able to, the visualization was good enough to remove some membranes and exchange PFCL against silicone oil, and we were able to save the eye. So the take-home message is we don't need, in every case, landers of Eckhart keratoprothesis. We just normal soft contact lens, it's enough. Thank you very much. Do you have any questions?
Okay, so I think we have got the Sanaullah is here. Okay, you can. I think Dr. Samir is going to give his talk. Last talk.
Okay. I would like to ask Dr. Slavomir about the last presentation, which was a very beautiful presentation. What's the visuality system you are using in your videos? It's a very nice one.
This is the new Leica. I don't make advertising.
Yeah,
This is the new Leica Provio.
Dr. Samir is going to talk about how to manage post-diabetic vitrectomy bleeding. After that, we have one more talk from Professor Sanaullah.
Bismillah ar-Rahman ar-Rahim. I will be talking about a very common problem for each of us working vitreoretinal, which is the diabetic vitrectomy bleeding. How to deal, how to attack this bleeding, how to stop this bleeding, how to solve and be prophylactic against this bleeding. First of all, attacking the bleeding can be preoperative or intraoperative or post-operative, which is post-vitrectomy vitreous hemorrhage. The preoperative systemic evaluation is a very important: blood sugar level and blood pressure, bleeding profile of the patient, anti-VEGF and PRP, injecting before the surgery and doing a proper PRP, anesthesia, local plus sedation is preferable than the GA, and we are going to discuss this later. So I'm going to show some papers that anticoagulation and the clinically significant postoperative vitreous hemorrhage in diabetic vitrectomy. Most of us tell the patient to stop the anticoagulation treatment before the surgery. And if you are going to do this, you should stop it before the surgery in 5 days and replace it by another treatment like Plavix or something. I don't want to speak about the commercial names, but the conclusion of this study says that patients undergoing diabetic vitrectomy who are on anticoagulation or antiplatelet agent do not exhibit a higher risk of intraoperative or post-operative vitreous hemorrhage, so that anticoagulants and antiplatelets may be safely continued perioperatively to avoid complications secondary to the systemic disease they have. So the conception of stopping the anticoagulants and antiplatelets before the surgery, this paper says that it's not important to do this, and you can safely continue the treatment. Does injecting the anti-VEGF or doing PRP before the surgery does differ in the course of the surgery or the success rate or in the percentage of developing post-vitrectomy vitreous hemorrhage? Yes. The conclusion of this paper is, which is a major review, the use of anti-VEGF agents before PRP results in superior function and structural outcomes at 3 to 4 months. This is concerning if you are going to do laser. But the use of anti-VEGF agents before pars-plana vitrectomy results in decreasing duration of surgery, fewer breaks, and less intraoperative bleeding. Although there is evidence for decreased incidence of early post-operative vitreous hemorrhage, the quality of evidence is low. So the available data support the use of anti-VEGF agents as adjuncts to PRP and pars-plana vitrectomy in patients with complicated PDR. So before doing diabetic vitrectomy, we can inject anti-VEGF. And we can do a proper PRP. This proper PRP before the diabetic vitrectomy will save time intraoperatively, will decrease the incidence of neovascular glaucoma, will decrease the incidence of post-vitrectomy vitreous hemorrhage, and will decrease the incidence of breaks as well, and detachment, retinal detachment post-operative. The intraoperative bleeding during vitrectomy for diabetic traction and retinal detachment with versus without preoperative intravitreal injection. The preoperative injection of bevacizumab was associated with reduced intraocular bleeding during 23-gauge pars-plana vitrectomy. So this is another paper which supports the injection of anti-VEGF before the diabetic vitrectomy for diabetic tractional retinal detachment. According to the post-vitrectomy vitreous hemorrhage, the incidence is about 50 to 55%, okay, in patients after vitrectomy. This randomized controlled study of intravitreal bevacizumab injected 1 day before the surgery for proliferative diabetic retinopathy, intravitreal injection 1 day before the vitrectomy. It blocked the vascular endothelial growth factor production in vitreous and significantly reduced the incidence of reoperation due to the early post-vitrectomy recurrent vitreous hemorrhage. So we came to conclusion that doing a proper PRP before the surgery and injection of bevacizumab or any other anti-VEGF before the surgery, 24 to 48 hours decreased the incidence of recurrence post-vitrectomy vitreous hemorrhage. Okay, this is before the diabetic vitrectomy. What about the hemostasis during the battle? Elevation of the infusion bottle, if you are confronted with hemorrhage, elevation of the bottle, this is one. Thorough endodiathermy to the bleeding points good shaving, and good membrane dissection. How to know the bleeding points? At the end of the surgery, if you are going to decrease the bottle, decrease the intraocular pressure to 10 millimeter mercury, for example, you will see the bleeding points at this point of surgery. So while decreasing the bottle, the intraocular pressure, the bleeding points start to bleed. Just do a proper diathermy. Good segmentation with diathermy of the vascular edges, decreasing intraocular pressure at the end of the surgery to check bleeding points, as I said, preventing post-operative hypotony and preventing post-operative cough or vomiting. The local anesthesia plus sedation is better because the general anesthesia will cause hypotension during the recovery of the patient, so it will open the bleeding points. So, first of all, during surgery, we should shave the vitreous base, as we see here. Shaving mode 6,000 to 7,000 cut per minute. Now it's 10,000 cut per minute, 150 millimeter mercury, extending the PRP, as we see the PRP anteriorly, going to the ora serrata as much as we can, shaving the vitreous base like we are going to see now. And it's better after the shaving to do laser, reaching as much anterior as you can, as much anterior to the ora serrata. This decreases the incidence of post-operative bleeding. Okay, this is a case of combined tractional and rheumatogenic retinal detachment. While doing the operation here, okay, you will see that there is bleeding will occur. You can stop this bleeding by the power of air, by moving from saline mode to air fluid exchange. This air fluid exchange, I am here doing diathermy to some bleeding points, and after that, by the air, I can stop the active bleeding, and I can as well to get the subretinal fluid and subretinal hemorrhage as we are going to see now, like what's called sandwich technique, like are going to see now. So using the air tamponade during the surgery may decrease the incidence of intraoperative bleeding. And as we see here, this fluid is very tenacious and very thick. It's just like the vitreous. So it's better to be removed by the cutter and not suction, only by suction and doing the cutter duty cycle, which is the core duty cycle. Okay, this is a very good demonstration of the dilemma of removing this stump or leaving the stump over the optic disc. Do we remove it or not? Every surgeon has this eager to remove it, but when you remove this stump, you may be confronted with this bleeding from the central retinal vessels, and it may be very hard to stop this bleeding till the end of the surgery. So here I tried to remove this bleeding using the flute needle, as we are going to see now, but it will still, and you can elevate the bottle, as we said. Sometimes you may inject some viscoelastic material over the optic disc. This may be a source of tamponading the hemorrhage. Okay. This is subretinal blood, as we see here, as we are going to see. This subretinal blood, you can remove it with the air tamponade, with the air fluid exchange, and as we all see here, doing diathermy to the bleeding points. After closure of sclerotomy, always avoid hypotony, because hypotony invites hemorrhage. So after, as we see, this blood trickled from me after the end of the surgery because of hypotony. So always avoid hypotony. Close your sclerotomies by good stitching to prevent this trickling of blood. Post-vitrectomy hemorrhage, we all see this, and it's better not to see it. Please do good homeostasis during operations, and as well, you have to put in your mind that silicone is not always the solution, but may be a problem. When you believe in silicone, you might have a bleeding behind this silicone and a very bad and very sticky amalgam, which may be very, very difficult to be removed. I will go rapid. Just I will show what the new instruments and the new techniques in stopping this bleeding intraoperative. The end aspirating laser probe. They invented a laser probe that is a laser and at the same time a flute needle. So you don't have to enter with the flute needle and get out and get by the laser again. You do both of them. Another instrument, simultaneous blood aspiration and laser, as I told you, and even by this laser probe, you can do diathermy. So it's a bipolar as well as a laser probe. Thank you very much, and I would like to invite all of you to Alexandria Vitro Retina Society meeting in Egypt, Alexandria, in 28 to 30 August 2024. Thank you very much. Shukriya.
Thank you very much, Dr. Samir. I think we'll have to invite the next speaker. We will take the question at the end. So I invite Sanaullah for his talk on trauma in Peshawar region.
Thank you very much.
Thank you, Dr. Samir. That was very nice presentation.
Kashif, and thanks to chair and co-chair for this opportunity. I was invited to talk on trauma in general, so I wonder why this topic is in this dense surgical retina session. But let's have a change and let me flavor this session with some general topic. So I'm going to present and talk about trauma in Peshawar. I'll be talking about what evidence is there, some summary of all these research studies published from our region, and then what should we do. So ocular trauma is one of the most common cause of unilateral visual impairment and blindness, with serious social and economical consequences to the community and psychological impact on the affected individual also. They need primary intervention, secondary intervention, and ultimately many more surgical intervention may be needed down the line. This is when I actually requested all my colleagues from our region they sent me all these publications which were regarding trauma in different journals, international and national journals. Myself, I have published more than 10 articles regarding different aspects of trauma. So I'm going to share with you summary or conclusion of all these studies. Ocular trauma contributes heavily to the workload in our eye clinics. They actually were 10% of all admissions and 50% of all admissions who were admitted in emergencies. They are due to poor services in rural areas, most of them presented to tertiary care hospitals. Closed globe injury, although more common than open globe, but they were less commonly hospitalized because they needed admission. Not all of them needed admissions. Male were predominantly affected. Children and young were more commonly affected. The young adults were actually the young who were involved in sports, fights, and in some of the occupation, like when they are labor or they were breaking the stone, things like that. So they received trauma while doing their professional jobs. Then road traffic accidents due to poor traffic laws and regulations and their implementation. Then talking about Peshawar and our province, for what comes to is probably the fighting and the bomb blast injury, but we found in all these studies that domestic circumstances and home is the most common site for receiving this injury. And scissor is one of the common source or agent of injury to the eye. Rarely the birds or the household hands, they would hit the eye of children when these are usually at home. Then second most common circumstances where the children received trauma was when they were playing outside streets. And they were throwing stones on each other with catapult or just by hand. The children who were playing games, especially the cricket, the tennis ball injuries were there. The firecrackers, especially in Eid holidays, tie pistol used to be there. They are now taken over by firecrackers. Wooden sticks, especially with the media influence in this Turkish series of Al-Tughral, it was very popular. So in these days, we started receiving trauma with wooden arrows. And then assaults, of course. Disposable syringes, also one of the agent causing eye injuries. And this is very unfortunate, but may not be there in Western countries or developed countries. But this shows poor control on waste disposal and its management. There was unnecessary delay in presentation and so its management. The tertiary hospitals are unnecessary overburden. And the treatment outcome were good, but if timely and skillfully managed. Violence or there were surges of trauma or eye injuries received during some of the time period when there was more bomb blast or security issues. The bilateral trauma were also more common in bomb blast or violence injuries. And you should be also vigilant regarding systemic injuries or life-threatening injuries when you receive patient with bomb blast injuries. Then they were very interesting that the ocular trauma patterns were different and they were changing. Like they may be influenced by media, as I already told you, like this Al-Tughral series, or they may be due to daily requirements, say like there is now more common use of solar panels and batteries at home. We used to receive battery explosion injuries while the mechanics would deal in their with cars or other batteries. But now we are receiving these type of injury in females who are who are at home and they are just probably there is some fault with these batteries and they are just asked to deal and check what's happening. It used to be that the stone is one of the commonest causes of receiving injury, but with increased popularity of cricket, the tennis ball took over actually. So these are some changing patterns and we need to identify these patterns. The house circumstances, home, sports, daily needs, all they are actually connected to this changing pattern of ocular trauma. Now, what should we do? The parents and community need to be educated. The children, while playing, they need to be supervised, and they need to groom to develop healthy playing habits. They need to have we need to have better control on an adequate hospital waste control. The traffic laws need to be followed religiously. Protective gadgets in sports and in different occupations are essential and can prevent eye trauma with serious consequences. We need to be vigilant regarding life-threatening injuries, especially in bomb blast injuries. The primary outcome should be better executed at primary, secondary care levels. You should provide the primary care, repair the globes if there is open globe injury at primary or secondary levels. And the tertiary centers need to be upgraded with essential all subspecialty services. And we need to identify the trends and changing pattern of trauma and then address them accordingly. War on terror or violence need to be focused, and the root causes needed to be addressed politically. Education, yes, we need to change the whole curriculum for our children. We need to focus more on skill and technology. The war heroes, which we glamorize in our curriculum, I think it's the time we respect them, then now we have to go for other heroes who are much more, who had much more achievements in information, technology, education, and all, and bringing peace to this region. Thank you very much.
Thank you, Snavla. That is a very, very interesting topic and very interesting causes that you have enlisted, especially the Turkish drama and Tugral and the changing patterns. And I was thinking at one time when there was war going on in Afghanistan, at that time Peshawar area used to get a lot of ballistic injuries and the bullet injuries and things like that. And now it has changed. We have started getting from injuries from the arrows. So we are moving back, I think, maybe. And the war on terror, I think it's outside the scope of Thelmo. So let's hope for the best. So any more questions from?
Yes, I want to ask
Yes,
the
please.
doctor a question. First of all, it's a very, very nice presentation, and thank you for enlightening these hazards for us. And you put the treatment, which is prophylaxis, better than cure. And I would like to thank you again for this very nice presentation.
Thank you very much.
I have the last question to Dr. Samir. Thank you very much. Very interesting presentation. But always my biggest concern and my biggest threat during vitrectomy is the choroidal hemorrhage while we indent. Would you advise do you think stopping anticoagulants helps in that cases to decrease the risk of choroidal hemorrhage?
Yes. Thank you very much for your question. We have a concept that stopping the antiplatelets and anticoagulants is mandatory before vitrectomy. The papers say other point of view, which you are not obliged to do this. Some patients stop these anticoagulants and antiplatelets and don't continue it after the operation, and they may have some strokes or some other coexistent disease because of their discontinuation of these drugs. According to the question of Dr. Slavomir, working with a good intraocular pressure and keeping an eye on the intraocular pressure while working, preventing hypotony post-operative by closing the sclerotomies, preventing trickling of blood, and preventing intraoperative and post-operative hypotony may solve this issue and may prevent choroidal hemorrhage as well.
So we come to the end of this very interesting and knowledgeable session.